Good afternoon, everyone. Thanks so much for joining us. I know people will continue to trickle in. It's going to be a smaller group today, so I think we'll have plenty of time for a conversation. My name is Amy Bruce. I'm the Executive Director of Patient Choices Vermont. So thrilled to have you all here, and I'd like to introduce Jen, who's been welcoming everybody. Jen Carlo is the Program Manager for Patient Choices Vermont. She supports and develops our outreach and education programs and supports our volunteers. I'm so thrilled to have her with us. She's still relatively new in her position, but has been going gangbusters. And this program, this monthly virtual program is something new for Patient Choices, and we're really pleased with the turnout. And if you've been to one previously, I hope you found it educational. We do them every month, so those will always be listed on our website, and they're always free and lots of interesting topics. So I'll turn it over to Jen and she'll describe what we're going to do today.
Thanks, Amy, and thanks to all of you for joining us today. We are taping today's presentation and we'll be spotlighting speakers so that audience faces are not always on camera, but if you're at all concerned about privacy, you're more than welcome to remain off camera and put anything you want where it says your name. It seems like just about everybody's on camera today, but we always want to make that option available. And please, if you've come in since I first invited people to do so, please feel free if you want to put your name and town in the chat so that we know who's here. Each one of these programs starts with a general presentation about Act 39 and medical aid in dying in Vermont. So I'll pause from time to time to allow for questions, but please, if you have any questions during the presentation, go ahead and ask those in the chat. And if you want to privately message Amy, you can do that as well just by looking for her name in the participant list. So we'll be as interactive as we can while we're doing the presentation. So let me quickly share screen. Okay, Act 39 and medical aid in dying. Again, please put any questions in the chat and Amy will flag those for me. So Patient Choices Vermont was founded in 2002 by a couple named Dick and Ginny Walters, who were aware that medical aid in dying was legally available to residents of Oregon, and they felt that Vermonters should have that same legal right. So they founded the organization to bring that about. They thought maybe it'd take 3-4 years to pass that law in Vermont. That was optimistic. It did take 11 years, but through a lot of persistence and advocacy and leadership, they were able to accomplish that in 2013. We're a nonprofit organization. We're funded entirely by donations and grants, no state or federal funding. And since the passage of Act 39 in 2013, we've worked to safeguard and improve the law. And as Amy said, we also provide education and outreach around Act 39 and medical aid in dying. And we have some wonderful volunteers who join us in that, many of whom are on this call. So, Act 39 legalized medical aid in dying in Vermont back in 2013. And then in 2022, there were a few adjustments made to the law. Telemedicine was allowed for the first time at the physician's discretion, expanded some legal protection, and also removed a final 48-hour waiting period that was included in the original Act 39. 2023 was really the bigger change in response to a lawsuit by a woman in Connecticut who wished to access medical aid in dying in Vermont, a lawsuit that was supported by PCV and some of our longtime volunteers. The residency requirement was removed, and now non-residents of Vermont can access medical aid in dying in our state, although all steps of the process must take place in Vermont and with Vermont licensed physicians. So there's a very specific definition to medical aid in dying, and I don't often read slides, but I do read this one, and then we're going to talk about some of the bolded points here. Medical aid in dying allows qualified adults who are terminally ill and who are capable of making their own decisions the option to receive a prescription medication to be self-administered to bring about a peaceful death at the time of the patient's choosing. It can only be accessed by qualified adults through a specific process. And there are very specific qualifications to access medical aid in dying in Vermont, and they are laid out in Act 39. You must be 18 years of age or older, and you must have both a terminal prognosis or diagnosis and a prognosis of 6 months or less. That's similar to hospice requirements. You must have the mental capacity to make healthcare decisions. You must make an informed and voluntary request, and you must be able to self-administer the medication. And this is true in all cases. All qualifications must be met in all cases. There are no exceptions or shortcuts. And I'm going to just pause here to see if anyone has any questions. All right, the process to access medical aid in dying in Vermont, you need to make 2 oral requests to a prescribing physician, and there needs to be a 15-day period between those requests. You also need to make a written request to the prescribing physician. It's a form that's kept by the Department of Health. It's on their website, and it's on the PCV website as well in our clinician's guide, and we'll put links in the chat to our website. You'll need 2 witnesses to that form, and they need to be not members of your care team and not related to you in any way. And then you need a second or a confirming physician to confirm all of the information and confirm that you qualify. We have found that many people would like some information about what happens on the day of ingestion, so we share that in these general presentations. Before a patient ingests, they'll take 2 medications for nausea, about half an hour before they intend to take the MAID medication. And then after confirming again that this is what they want to do, the patient needs to drink the medical aid in dying medication without assistance. It's a compounded powder of several medications, and it's mixed with a small amount of clear liquid, generally apple juice or water, about 2 ounces. So the patient needs to swallow all of that, and then they will fall asleep within 5 to 10 minutes, and they will not awaken. The time to death can be variable depending on the patient's general condition and various other things that the prescribing physician should watch for and make sure that the family understands. Most folks will die within about 5 hours, although the time to death can be longer. The patient will remain asleep, will remain in a very, very deep sleep. They will not be aware of what's happening, but it's important to make sure that the family is prepared for that. We strongly recommend hospice enrollment for any number of reasons. All of the services that are provided by hospice, symptom management, and also because if a patient is under hospice care, their death can then be pronounced by a hospice nurse. Medical aid in dying is voluntary, and that's true for everyone in the process. Qualified patients can choose to pursue MAID. It's always the patient's choice, and you can stop the process or rescind a request at any time. You can go to the initial appointment with your prescribing physician and then decide that it's not something that you want to do. You can go all the way through the process, get a prescription, and then not follow through with that for any reason that you choose. It's voluntary throughout the process. It's also true that healthcare providers are not in any way required to participate in medical aid in dying. And in fact, doctors who prescribe MAID medication must inform their patients of all of their end-of-life choices so that everyone's decision can be as informed and voluntary as possible. We do have some resources both on our website, and when we do in-person presentations, we hand out physical cards just to help you talk to your doctors. Has some sample questions, and if you need one of those, please let us know. And again, we strongly recommend hospice enrollment. That's so important that we put it on 2 slides in a row. Medical aid in dying is not suicide. There's legal, practical, emotional differences there. If you use medical aid in dying, it is considered your last form of medical care, and your death certificate will reflect that. It will reflect a death caused by your underlying condition rather than a suicide. Medical aid in dying is not euthanasia. It's something that the patient has actively chosen through an informed process and administered themselves. And medical aid in dying is not for everyone, and we respect everyone's choices around this. So here's a timeline in the last 2-year period for which statistics are readily available, and that's July 1st, 2021 through June 30th, 2023. That's kept with the state's fiscal year. Medical aid in dying in Vermont was used by about 85 Vermonters. Those are the Department of Health statistics. In the 10 years since Act 39 became legal, or was passed in 2013 and MAID became legal in Vermont, MAID has been used by about 203 Vermonters over those 10 years. And that shows a fairly slow but steady increase, which is what we'd expect as more people become aware of medical aid in dying and what the process is. And that still represents, we think, just about under 1% of all of the deaths in Vermont in a given year. So the statistics that we're watching for now are the ones from July 1st, 2023 through June 30th, 2025, because those will be the first statistics that encompass out-of-state folks who came to Vermont to access MAID. The Department of Health has those statistics, but they're legally required by Act 39 to present those to the legislature first. And so we're anticipating that they will do that in early 2026, and then they'll be able to publicly share those, and so will we. We're anticipating probably, again, a small steady increase in the amount or in the number of Vermonters who access MAID in a given year, and then we'll see the increase of the out-of-state folks. Right now, medical aid in dying is legal in 11 states and the District of Columbia, and we are watching New York, where the legislature has passed a bill legalizing medical aid in dying. Governor Hochul has until the end of the calendar year for them to send her the bill and for her to sign it or not. So we're watching that. And Illinois has also just passed both houses of the legislature, and that bill will go to Governor Pritzker at some point. And there are various processes in place, in progress in other states. So we'll see what happens in the coming year. One of the things that people always ask, are very curious about, and understandably so, everybody who works in this space watches this very carefully, and we are unaware of any reported incidents of abuse of medical aid in dying in the US. And there are various organizations that connect all of the folks who are working in this space across the different states where it's legal. And we can assure you we watch that all very carefully, and there are none that we know of. So I would encourage everyone to take a look at the Patient Choices Vermont website. You're going to want to do that probably a couple of different times because it is chock full of information and you'll want some time to absorb it. But it's pretty well organized, so you should be able to find anything that you need there. There's descriptions of the qualifications, the process, everything we just went over here. There's links to the various forms. And there's some personal stories, patients and family members who have used medical aid in dying from their perspective. There's a great clinician's guide, and there's a calendar page where you can find out about the next exit matters, for instance, or when we might be coming to a library or a senior center or another public location near you to give a presentation. So watch our mailing list for that. There are a couple of different groups of volunteers who work with PCV. There's a Wayfinders Network. They're affiliated with PCV. They're not official volunteers, but it's an independent and collaborative group. And they work primarily with folks who are coming to Vermont from out of state to utilize MAID. And that may include helping finding physicians, an ingestion site, or other kinds of practical support. We also have a helpline. We have, and we'll put a link in the chat to the helpline page on the website. Comes in primarily through web forms. Anyone who has questions about medical aid in dying in Vermont can write in with as much of their personal information as they care to share. And we have 4 volunteers, wonderful people who spend a week at a time responding to all of those requests for information and help. And we found that really just making connections with a person who can answer some questions or provide you some links can be a great comfort for folks who are seeking that information. We have some additional resources here. Compassion and Choices is a national organization that supports state organizations like ours and works to support groups who are working to legalize MAID in other states. And there's a Dartmouth Dementia Directive. We get a lot of questions from folks who are struggling with or living with dementia and how that intersects with MAID. So these aren't endorsements, but they're other places that you can go for additional information if you so choose. And we'll have a recording of today's presentation on our YouTube channel and on our website. And yeah, I think that's about it. Any questions? Well, we will crack
There
up.
is a question that
Oh,
just popped into the chat asking about insurance. I'm assuming you're asking if insurance covers medical aid and dying services. And the answer to that is you do need to check with your own insurance company and the prescribing and consulting physician that you would be working with. Insurance generally does not cover the cost of the medication. In Vermont, that cost is currently about $750. And providers cannot bill Medicare or Medicaid for very specific care on medical aid and dying. They can certainly bill for palliative care consultations and more general end of life comfort consultations, but not specifically MAID. So whether or not an independent insurance company is going to cover it would be up to your own insurance.
I have put into the chat first the specific contact form if you want to reach out to our helpline with any questions. I've also put our website, the main page of our website, and my email if you have any follow-up questions or want to be in touch. Also, wondering about the experience of families when the death takes a long time. Does it always work? Yes, with this formulation, it will work. And the experience of families when it takes a long time can be variable. That's why we encourage patients to make sure that they're in close contact with their prescribing physician to try to identify any red flags that may be present in a particular patient's health journey, so that they can maybe anticipate if the physician thinks that maybe death will take a little bit longer than the average, just so the family will know. Again, the patient will be deeply, deeply asleep. The patient will not know, but the family should be prepared. And yes, of course, family, friends, a support system. It's really up to the patient when and how they do this once they've gone through the MAID process and who they want around them.
And just to clarify, thinking about what you might be thinking, Kate, with that question, this generally takes place in private homes. And so MAID deaths don't occur in hospitals or facilities for the most part. And so people, whether you live in Vermont and you're at home or you're coming to Vermont, people do need to find locations where they can safely and comfortably take the medication and have their support team around them.
Marlon,
If hospice is not involved, what is the process for certifying death?
Amy, you want to take that?
Yeah, so they would generally need to call first responders unless the prescribing physician is in attendance. Of course, if the a physician is there, then they would pronounce death. But if there's not a hospice nurse, then generally one of the reasons we strongly encourage hospice is because it is possible that there would need to be a coroner's investigation of the death, an unexpected death, and so there may be first responders coming and so, yep.
And disposition of the remains? What is Vermont's process?
So again, it depends on if you're a Vermont resident, if you're coming from out of state, then that is something you would work out with your support team, ideally hospice, and they could connect you, you could talk with them about what your plans are, and then the body can be transported as needed. And that would all be done ahead of time. And if you're working with one of the Wayfinders in the Wayfinder network, they also help people through that process.
And my understanding is you can be buried on your own property in Vermont?
Jen, do you want to know, I know that we
Yes.
have the natural cemeteries, but Jen, what is the
Yes.
law around your own property?
Yes, and we know this actually because our November program was around natural burial, and there was a question that came up. And yes, there are guidelines through which you can be buried on your own property in Vermont. We know that to be the case. I would not want to get any more specific than that, to be honest with you. I would send you to Google to look for that policy in Vermont. I know that there are certain things that you need to do in order to do that. There's probably a permit involved depending on where you live. But if you want, Marlon, send me a message or put your email in the chat, and I can also connect you with our November speaker from the Vermont Forest Cemetery, or Tony's raising her hand. So.
I'll finish what you were saying first, Jen.
No, I was just going to say, Marlon, I can connect you with some folks who would have more information about that. I just know it's legal. I don't want to give you bad information, but now Tony has some.
I'm sorry. I seem to have lost my raise my hand button, so I just raised my hand. Referring back to the question about pronouncing death, it kind of relates to the topic of today's presentation, I think, advanced directives, because yes, EMT would come in and pronounce death, but there needs to be a COLSTs or some sort of do not resuscitate documentation on hand immediately, or they will be placed in a very difficult position and legally have to resuscitate. So just wanted to add that.
Thanks,
It's
Tony.
it's one of the main reasons why it's great to have hospice there. That and to pronounce the death and to assist with the removal of the body.
Absolutely.
Thank you, Tony.
Kate has one more question in the chat. Should a patient wait until the disease is within 6 months of death to begin the process? That's a requirement for the formal process, for the appointments with the prescribing physician and then the confirming physician. You need to have both the terminal diagnosis and the 6-month prognosis to start the formal MAID process. But we do encourage people to explore options with their physicians, with their care team, well before that, if they want more information. There have been folks who have come to these programs kind of seeking information and just trying to kind of picture what the process might be if and when they come to that. You can't talk to your Massachusetts doctors about this at all. Any advice? I would say write to us through our helpline, and we can send you a number of resources where you can get more information, similar and more than what we're giving here, and we're happy to provide all of that information to you. Massachusetts doctors certainly cannot prescribe for medical aid in dying. Only Vermont licensed physicians can do that within Vermont, but we've also found that there are physicians in other states who are willing to kind of at least have a broad discussion and possibly refer their patients to colleagues in Vermont if they happen to have those connections. And again, I did put the link to our contact forms on our website earlier in the chat. So if it's okay with everybody, I'm going to crack on with introducing Amy and Cindy so that they can do their presentation. But again, my email's in the chat and I'm going to put it in there. Again, our contact information is in the chat. We are happy to continue this conversation and give you any information that we possibly can. So Delighted to introduce our speakers today, PCV's Executive Director, Amy Bruce, and our colleague, Cindy Bruzzese, who is the Executive Director and Certified Clinical Ethicist for the Vermont Ethics Network. Amy came to PCV late last year. She has an extensive background in palliative and hospice care in California and Maryland, and she's long been a strong advocate of medical aid in dying, as well as bereavement support for families. She has a master's in public policy, and in her, I happen to know to be non-existent spare time, she's an avid outdoors woman, hiking, skiing, all kinds of great things. Cindy is a clinical ethicist for the UVM Medical Center, in addition to her Vermont Ethics Network responsibilities, and she chairs the Ethics Committee for the State of Vermont Department of Disabilities, Aging, and Independent Living. She also co-chairs the Central Vermont Medical Center Ethics Committee and directs the statewide task force on palliative care. Cindy holds a master's in public administration, a master's in clinical ethics, and a certificate in bioethics, with a specialization in health policy and law. She's a native Vermonter, and her family, in addition to her husband and children, includes a black lab, a horse, and a miniature donkey. So maybe we'll have time to ask her about that later. So turning it over to Amy and Cindy. Thank you so much for being with us today.
Thanks, Jen.
Okay. Thanks, Jen. I think I'll just go through what we hope to highlight today, and then invite Cindy to take over. Feel free to, again, put questions in the chat as we go. And I know I'll have a little bit of time after 1 o'clock if people want to stay on, but we'll try to wrap things up at 1. So here we are at holiday time once again, and we thought about the fact that we all, if we're fortunate enough, we gather together with family or our close friends, and we notice things about one another. If we haven't seen one another for a while, we might notice some changes, or we might hear about a hospitalization that occurred that no one happened to mention back in July. And so some things start to, percolate up about, what are our plans? So we want to talk about why it's so important to voice your wishes, think about what your wishes would be if and when you can't speak for yourself, and talk to the people that you're closest to about those. And then once you've gotten that conversation going, explore the different tools and documents that exist to help make those formal, and then how to keep track of those documents, where they need to be, and how they can be available when you need them. So we'll talk about advanced healthcare directives, the importance of naming a healthcare agent or power of attorney for healthcare. We'll talk about what Tony mentioned, a COLST form, sometimes called a MOLST form, a clinician's orders for a life-sustaining treatment form, how that's different from an advanced directive. What happens here in Vermont if you don't have any of this designated, if you don't have a healthcare agent, because it does differ state to state. And then how and when you want to think about updating these documents, because it's wonderful when people get this work done, but it's not a one and done. As your life changes, people in your life change, you change. You need to look back at those documents and think, is that still really what I want? And are those people still with us? And is that who I would name today as my healthcare agent? So that's the breadth of things we're going to try to talk about in the next 30 minutes. So I'll go ahead and turn it over to Cindy.
Let me know if that is sharing. You should see a contemplative person who is thinking about their future. This is sort of what I do most of the time when I'm at the Ethics Network, if I'm not responding to actual ethics consult requests, is supporting people of all stripes, whether they're healthcare practitioners or folks in the community, to just sort of think about planning for the future. And, when I think about advanced care planning, I think about having some time and space to think about and also talk with others about the what ifs that could happen as we're aging, right? I mean, sudden, unexpected things happen to people all the time. New diagnosis, a fall, riding a bike on the potholed roads of Vermont, right? I mean, there is, none of us are immune from those sudden and unexpected things happening that could leave us in a situation where we aren't able to speak for ourselves and engage with our healthcare providers and talk about what our priorities are or what's important to us. And so, who do we have? Do we have a team or a person or anyone who can be that go-to person if I can't do it for myself, either temporarily while they're trying to get me better, or maybe permanently because of something that has occurred or a progression of a disease? And so this is what advanced care planning really is. It's that sort of just thinking about the what if. So you don't have to be dying or have a terminal illness to do advanced care planning. In fact, I think maybe that was a mistake we made with advanced directives early on in their inception, is kind of framing them all around end of life, because you don't actually need to be dying to need one of these documents, because we know that I think I was at a talk at Dartmouth years ago, and the speaker said that some ridiculous number, like 95% of us will lose the ability to speak for ourselves at some point, even if it's temporarily, right? Like you can imagine, like it just might happen for you hit your head, you got a concussion, you can't speak for yourself. That could happen even at a young age, a young adult age. So this is something we should all be doing and revisiting. As Amy said, it's not really a one and done. But when in the context of certainly of medical aid and dying, or people who are thinking about their future health, what kinds of things should I be thinking about? Like that's the, like thinking about what. And so think about what makes you happy, what brings you joy, what are the kinds of things you enjoy doing, what does a good day look like for you, what worries you about the future and your health. Have you had any experiences with the healthcare system or with treatments for your health? And what has that been like? Has that been good and you would be really open to spending time in the hospital and having more medicalization? Or is that not so great and you'd really prefer to avoid being in the hospital? These are helpful things for your family, your friends, your healthcare providers to know about you, because then they can frame a care plan that sort of reflects the things that are most important to you. What would be your goals if you knew you couldn't recover from your illness? What becomes most important then, right? When recovery isn't really possible? Are there situations that would be unacceptable? Like, absolutely not. I think we can all think of, I think that it's probably an infinite list of things that would be acceptable, but maybe the list of unacceptable things is very small. And that might be something that you could easily communicate, the hard stops, the things that would not be okay. Are there treatments that you're definitely sure you would want to pursue? Maybe there are treatments that you know right out of the gate, that is definitely not for me. That is not something I'm willing to do. Maybe you're just like, listen, I'm open to most anything as a trial. See if it's working. If it's not working, then I don't want to keep doing it. And then is there anything else about you that your family, your healthcare team, your friends really should know in order to take good care of you? So this is really something that's personal to you, who you are, how you live your life, what's important to you. These are the kinds of things to be thinking about when it comes to advanced care planning, and ultimately speaking to those people who know you well to make sure that they know these things about you, because that's how they can be a good advocate for you. And also sharing that with your healthcare team so that they have that as part of their game plan when they're thinking about treatment care plans and things like that. And so those are the kinds of things that I think are helpful to be thinking about in advance. And notice they're not all about end of life, right? They're not all about dying. They're about living well. And how do we help you live well as long as possible? And how do we make sure we don't send you down a path that is absolutely inconsistent with who you are and what matters to you? And that I think is really important. Certainly as an ethicist, these are the kinds of questions I get when we are down a path that this is not consistent with who this person is. How do we get back on the right track? Whoops. Then it comes time to documenting, and we've spent a little bit of time already thinking about this, but what form? There's so many forms out there. How do I know which form I'm supposed to use? And I think in Vermont, you can use any form you want, which I think is important for people to recognize. There's not one particular form that you have to use. So find a form that meets your needs right now, understanding that you update these things. It's expected that you will update your advanced directive, right? I mean, unless you're doing it literally, you know, weeks to months before your death, it is likely that you will go through a few iterations of one of these documents. So don't worry about it if you're like, I don't know the answer to some of these questions. Don't pick a form that asks you a bunch of questions you don't want to deal with. Pick a form that addresses the things you know you want to communicate right now, and know that as time marches along and you revisit these documents, you may be like, oh, I think I need a different form now because there are other things I want to communicate. Certainly my kids, all we did was appoint a healthcare agent when they turned 18 and 20. That's it. We didn't talk about dying. We didn't talk about treatments. We didn't talk about CPR. We didn't talk about any of that stuff. These are young, healthy kids who are going off to college. And we just wanted to make sure that we had a legal decision maker should something unexpected happen. So feel free to give yourself permission not to do it all at once. If you don't feel like it or you don't want to, that's okay. Make sure, though, if you can, I would say if there's nothing else that you do, the one thing that's really important is to name a healthcare agent if you have someone that you trust that you can name. It's not required to name a healthcare agent. You can still do an advanced care planning, advanced directive document without an agent, but it's helpful if there is an agent, mostly because by the time we're looking at your document, we're not able to speak to you to get information directly from you. And it's really hard to think into the future too far and to know exactly how you're going to feel and what you're going to think about certain things. So it's sometimes helpful to have another person. It's often helpful to give context, to talk about what's changed, what's different. Have there been other conversations that you've had more recently that maybe aren't reflected in the document that are really important for us to know about? So if you can appoint an agent, I would highly recommend that as a starting point for any sort of advanced care planning. And then as you're looking at forms, maybe you want to do the mix and match approach. There was already a reference put up about the Dartmouth Dementia Directive. It's almost like we coordinated, which we didn't, but I did mention here that if you're going to combine forms, that's fine too. You could just make sure that in whatever document's going to be the one that's the legally signed and witnessed document, that you reference any addendums you're attaching, like a dementia directive, and say, see attached dementia directive, so that we know and whoever's looking at it knows that this is all part of the same document. So I'd say, really give yourself permission to find the form, to customize it to meet your needs. That's the point. None of advanced care planning is the same for everyone. The whole point is that these are individualized documents that reflect your values. They're not intended to be sort of the same for everyone. So do what works for you. When you think about the basics of advanced directives, obviously we talked about naming a decision maker. This is called different things in different places. It's also called different things over time. In Vermont, we called them durable powers of attorney for healthcare until 2005. In 2005, we changed our law, and now we call them healthcare agents. They're the same thing. Some states call them healthcare proxies or proxies. Depends on where you live, but what this is this is the person who has been named by you in advance to be your legal decision maker, right? That's what they have. And they have all the power that you would have to make decisions, to view your medical records, to speak to clinicians that you would have if you had capacity. You have to be decisional when you do this, and you can't appoint anyone that's not at least 18 years of age or older. So that's the naming of a healthcare agent. The other piece of advanced directives, I think, that then starts to get into the what, which is, what are your values? What's important to you? Who are you as a person, and what matters? And this is where we get into treatment directives. We used to call them living wills. But the living will over time was just not, it just didn't work the way people had thought, because living wills literally are about, if my condition is terminal, and there's no hope for my recovery, this is standard language in a living will, I only want care directed at my comfort, and they want to forego other types of treatments. Well, we know that advanced directives aren't always that cut and dry, and we might need them before you're dying. So having a living will that only speaks to an end of life scenario wasn't all that helpful. It also talked a lot about, I don't want any extraordinary measures. Well, back in the 90s, ventilators were more extraordinary than they are today. Some people might think of a ventilator as an extraordinary measure. Most people think of a ventilator as kind of just what you do if someone has a bad pneumonia for a period of time. It's really not that big of a deal, but it might be a big deal to you. So, as a tool, living wills didn't work all that well to accomplish the goal. And so, most states in the early 2000s went through a whole revamping of their advanced directive laws to try to address how do we make tools that are a little bit more helpful when a person lacks capacity. And where we landed was these treatment-based, goals and values-based treatment directives that really allow us to get more into the what. What's important, what matters, where are the hard stops, some of those questions we talked about earlier. So these are preference-based documents sort of aimed at forecasting into the future when you can no longer speak for yourselves. And they've, the language has kind of changed around them, but when someone says I have a living will, I'm assuming that they have an advanced directive of some stripe that probably speaks to an end of life scenario. But these are documents that you should take a look at and update over time, because we know that your goals and values change as you age, as you develop new and different relationships, as you develop maybe new diagnoses, things shift and priorities shift. So any questions about advanced directives specifically, or designating a healthcare agent or anything like that? It's probably review for all of you, but it's so nice to sort of make sure we're all using the language and talking about the same thing in the same way.
Cindy,
Yeah.
you alluded to this, but if you have an advance directive and you've named a healthcare agent and you're in the hospital and the providers, the clinicians are talking with your agent, and the agent says, I know that advance directive is outdated and what they've told me they want today is X and it's different than what's in the advance directive, will that healthcare agent's decision be the prevailing decision?
Well, it depends. And
Okay.
that's probably the most honest answer I can give you. It depends on what they're saying, what's being requested, what the patient's actually saying, even if they lack capacity, because even when you lack capacity, patients retain certain rights around various different healthcare decisions. And so it does kind of depend. In general, I'd look at the date of the advance directive. Like I'd get called probably as an ethicist to help sort some of this out. So I would be looking at the date. How old is this document? What's changed from when the document, like from a medical standpoint, from a health standpoint? Because people are completing these arguably when they're well, right? When they're fully capacitated and doing well. Some documents are very recent and some are very old. And so if I have a very recent document and a family member saying, we want to change course, and what's the clinical scenario, like it can get tricky. So there's a lot that goes into it. But in general, we give a lot of weight to healthcare agents, but they are held to a certain standard within the law. So that standard is called something called substituted judgment. And so they have to provide some sort of evidence for what they're saying, right? Knowledge, direct knowledge of the patient's goals and values. And advanced directives are a very strong legal document that gives us direct knowledge of a patient's goals and values. So we're not generally just saying, okay, whatever you say. I mean, we want to dig a little deeper to figure out the reason you're changing course truly based on knowledge of this patient's goals and values that have shifted? Or is this often the case, which is sometimes family members are feeling not ready, not ready for what the document might say, in which case they need more time. Mm-hmm. And so we try to tease that out because it's not really okay for healthcare agents to do a 180 on somebody's goals and change course without some sort of evidence. So were there conversations with a physician, something that was documented in the record? Is there more to it than that? And there's plenty of people that just have named a healthcare agent and we've got nothing to support what they're saying. And so then we're asking questions and trying to say things like, what would your mother think about this? What would your mother tell us about being in the hospital for a prolonged period of time? How would she feel about that? So we're setting that person up to answer in the voice of the person who's incapacitated and not answer in their own voice, which is, I'm not ready. I don't think my mother, you know what I mean? Like, I don't think this is the right thing for my mother, but that is more to do with you. So it's kind of a long answer, but obviously when you ask an ethicist a simple question, it's never a straightforward, simple question, right? I mean, and I'm not
And that's
trying
a
to
good thing.
pun.
And that's a good thing. No, I thank you very much. That's really helpful.
Yeah. Any other questions about advanced directives or? Okay. When you do one in Vermont, we want you to make some copies. Keep the original for yourself and write down who you gave copies to. Because if you're going to change it, you want to make sure all those people have updated copies and you want to be able to look at it and reflect back on it and see if you want to make some changes. It'd be great if you obviously should give one to your healthcare agent and presumably you have spoken to them about it and they are willing to serve as your agent or your co-agent. And I think it's helpful to give it to other family members who are likely to gather because it's nice when everybody's sort of operating from the same playbook and we don't have family members who aren't decision makers questioning decision makers as to why they're saying what they're saying. And sometimes it can get kind of contentious. So it's nice if everybody knows what the game plan is. Not always possible, but it is nice if you can do it. Make sure your doctor has a copy, the hospital where you're most likely to receive care, and then if you're open to it, we have a registry in Vermont that's free to all Vermont residents where you can send a copy of your document and then it's readily available. Hospitals can access the registry immediately, so we're not waiting for somebody to find it in the junk drawer of the bedside table or worse at the safety deposit box at the bank, which is never open when we have the emergency. So we have a registry. We've got over 60,000 Vermonters in the registry now. So the likelihood that a hospital, when they're looking for someone, will find someone's document in the registry is getting higher and higher and higher, the bigger the numbers are. So those are the options. Any questions about the registry or what to do with these documents afterwards? The registry is actually based in New Jersey. However, the Vermont Ethics Network has taken over the responsibility of doing all the uploading of documents if you're not doing it yourself. So you're no longer mailing or faxing your advanced directives to New Jersey, which was the case since 2007 up until 2 years ago. Now everything comes to the office at the Vermont Ethics Network, and we are processing people's paperwork to get them uploaded and their accounts created or updated if they've already done one and they're updating. It just has change of the business model for the registry, but the actual repository, the bank where they're being stored is at USACPR. It used to be called US Living Will. It's a national registry. And the nice thing about it is that it is national and it's web-based, so you can access it from anywhere. So if you're in a hospital in another state, they could also access the registry for you. But we're doing all the customer support and the upload now just to try to make it easier for Vermonters to get their documents in there quickly. So this is all updated information here for where to send them and who to email if you have questions, because we're doing all the customer support for that as well now. It just got kind of big for the folks in New Jersey, so we're doing it. That makes some Vermonters happy because now they're not mailing their document to New Jersey, which was probably the #1 question that I used to get, which is why am I mailing my Vermont Advanced Directive to New Jersey? So now you're sending it to Vermont, just sending it to Montpelier. Tony brought up the issue of COLST orders, and I think these are hugely important, particularly for people. I think advanced directives are important for people that are thinking about and considering medical aid in dying, because I think it's hugely important, even if you can't designate someone to activate medical aid in dying on your behalf, you still have to have capacity. It's important to know your values. And it's equally important for you to have these portable medical orders. And that's what DNR COLST orders are. They're portable out of hospital medical orders. DNR, as you know, stands for Do Not Resuscitate. COLST stands for Clinician Order for Life-Sustaining Treatment. They're medical orders. They're not advanced directives. They're not advanced directive on steroids. They're a completely different advanced care planning tool, right? They're medical orders. They require informed consent and a signature by a clinician documenting that you understand what it is you are saying yes and no to as documented on that medical order. They're really used to limit certain treatments. They're binding across all healthcare settings, including in emergencies with EMS. Advanced directives are not the same. Advanced directives are great tools for non-emergencies when there is time to have a conversation about what's going on and to make a plan. They are not good in emergencies, and they are not used in emergencies. So even if you have an advanced directive where you checked no CPR, that will not work in an emergency. That will work when you get to the hospital and we've figured out what's going wrong with you and we've decided we're not going to pursue resuscitation if it comes to that when you're in the hospital. And they will institute a DNR order afterwards that's for the hospital, but it won't work in an out-of-hospital setting. You need a portable DNR order for that, which is why I think, as Tony alluded to, if the medication is going to take a long period of time, or at the death pronouncement, if there isn't hospice available and EMS is called, if they don't see one of their orders, their standard protocol is to initiate resuscitation. So this is why you need one of these orders. It does address in general questions about resuscitation, the issue of intubation and ventilation, artificial nutrition and hydration, and provide some overall guidelines for medical treatment, just about how much or how little you want. It's intended for seriously ill patients or for people who are certain that regardless of why the situation has occurred, they would never want certain things. So it doesn't matter why. It doesn't matter if I choked or if I, my heart failed. I do not want CPR. I do not want to be intubated. Doesn't matter if it's reversible pneumonia or if it's end-stage COPD. Do not put a tube down my throat. And those are things to consider, right? So an order is really only works like this if you know you never want it. Right? Otherwise, you just need a good, if it's dependent on the circumstance. So if then is in your thinking. If it looks like this, well, then I would want it. If it looks like that, well, then I wouldn't want it. You don't need a DNR order or a COLST. You need a good advanced directive that spells out the scenarios where certain things would be acceptable and certain things would not be acceptable, because you'll need time to figure out which situation you're in. These orders are intended to guide the current care plan, not a future care plan, what we're going to do right now, tomorrow, if something sudden happens. So everyone, I think, who isn't under guardianship and who is an adult should have an advanced directive. Some of those people will need a DNR COLST order to ensure that certain things don't happen because they know they don't want them. Does that help to sort of distinguish who needs what? Like, I have an advanced directive, but I do not have a COLST order. And that may change as I get older. And where you put these things are different too. You don't put these in the advanced directive registry because they're not advanced directives, they're medical orders. You put these in your place of residence, generally on the refrigerator, sometimes in the refrigerator, depending on where you live. In Washington County, you don't put them in the refrigerator because the EMS providers have told me they all fall down and are hidden behind the beer. If you're in Williston, you put them in the refrigerator in a tube called the Vial of Life. They're not a bunch of big beer drinkers in Williston, apparently. That's what the EMS has told me, that they want them in the fridge. Most places want them on the fridge. Certain settings, David, you might know where they go at Wake Robin. Certain settings, they have a cupboard, or there's a specific place in a residential care facility that EMS knows who goes to that facility where these documents are found. So, but it needs to be readily available. They're not going to hunt through your mail. They're not going to look through a bunch of places to try to find it, because they need these quickly, because they need to know if I'm doing it or not doing it.
At Wake Robin, they are always in the bathroom cabinet.
Always in the bathroom cabinet. So that's the plan for Wake Robin. And my guess is EMS knows that, because if they come to Wake Robin, they've been told this is where to look. So
And
it's really
Cindy,
important.
I'll just
Yeah.
say I'll just give you the 5 minute.
Okay, great. So basically, I mean, I can summarize here so we have a little bit more time to chat. Um, Advanced directives, think future oriented at a time when I can't speak for myself, probably some nuance involved in terms of needing context, interpretation, some sort of assessment of what's the prognosis, can we fix it or not fix it? Because if we can, we're going to go down this path. If we can't fix it, it might go down this path. And only a person with capacity can complete one and can update one. So once I lose capacity to make my own decisions, my window to update my advanced directive or to do one is over, and nobody's completing one for me. COLST order, different animal. Portable order, shared decision making with your clinician, requires informed consent. It guides the current care plan. It's based on your current medical condition and your goals and values, trying to match those up with what makes sense. And consent can be provided by someone who's not you. So your healthcare agent could consent to a DNR COLST order once you lack capacity. Very different from what you see with an advanced directive. And I think I'll end there. Just I wanted to distinguish those. And let's chat a little bit more.
We do
Any
have a
questions?
question in the
Sure.
chat from Kate. My care team gave me 5 wishes. It's a care packet for end of life wishes, and she's wondering if you're familiar with that.
I am familiar with it. I am familiar with 5 wishes. A lot of people like that form, and that would be a perfectly legal form. In Vermont, the signing and witnessing requirements, if you're going to use a form, you just have to, in any state, depending on what their law says, but most states aren't too rigid about what form you use, it has to comply with the signing and witnessing requirements. So in Vermont, it has to be signed with 2 witnesses. No notary. You can't use a notary in lieu of having 2 witnesses. So just make sure. I think the 5 wishes form is set up to comply with Vermont standards, but wherever you live, you just want to make sure that whatever form you use complies with the legal framework that is required in your state.
Thank you. Anne, do you feel comfortable explaining your post a little bit?
No, it was just after every Thanksgiving I give a little talk to my siblings, and this was a great article to follow up in. It was in the New York Times like on Sunday, and it's all about, is the patient going to be heard and what the last 12 hours of his life could have looked like if somebody had heard him.
Got it. Got it. Thank you for that. Other questions for Cindy or Amy?
Should we take a poll? How many people have an advanced directive? Oh, look at all you great people with your hands up. I can't tell from the people who don't have their cameras on.
Meg, and then Amy and Tony have also raised their hands. I'm not sure if it was in response to that, but.
In response.
Oh, okay. Amy and Tony, you were raising your hands in response to that?
Zoom saw that and put that little icon up there for you. You never know what Zoom's going to do next.
I don't even know how I raised my hand.
Yeah, it's because you raised it manually, so Zoom saw you.
That's frightening.
But fabulous. It looks like a really proactive group. So you can go out and tell all your friends that didn't come to the webinar
That's right.
what you learned and that you'll help them if you've done it.
Any other questions? I'm also going to note, Marlon, I took a second to go look, and I just put a link. It's the Vermont Health Department private property burials guidelines on their end of life decisions section on their website, which is really pretty good if anybody has the opportunity to take a broader look. But that's specifically the information that you were asking for about private property burials.
All right. Well, we just hit 1 o'clock. I'm so grateful to all of you for sharing some time with us today. Thank you so much, Cindy, for sharing all of your expertise in the Vermont Ethics Network. Their website, again, has these forms available, and then you can do them, and then they will, like Cindy described, upload them to the registry for you, and you can take that worry off your mind. Jen, thanks so much for getting these together every month. Like Jen said, well, go ahead.
Absolutely. I just had a couple wrap up things. I'm sorry, I wasn't trying to interrupt.
Yeah, no, that's fine. You wrap it up for us.
All right. As we said earlier, Patient Choices Vermont is entirely privately funded and mostly composed of volunteers. So if you would like to support our efforts, I've just put a donation link into our chat. And as we also said earlier, the recording of our presentation today will end up on our YouTube channel and our website. So if you're interested in that or in any of the programs that you missed, I've just put that link in the chat as well to our videos. Our next upcoming Exit Matters will be at the end of January. I believe it's the 29th. It's a Tuesday evening, and our speaker will be Dr. Diana Barnard talking about Palliative Care 101. So please make sure that that you keep registering and coming back for these programs. And we are, as Amy said, very active out in our communities, presenting at libraries, senior centers, really anybody who would like to have us. And so if you you have any suggestions for us or would welcome any kind of presentation in your community, or if you just have other questions that you don't necessarily want to share with the group or that don't occur to you until tomorrow or after, I've just put my email back in the chat as well. Thank you all so much for joining us.
Thanks, everyone. Happy holidays.
I'll also linger just
Happy
for a minute if
holidays.
anybody has anything else. So thank you so much.